Hi, everybody. I want to welcome you to our bi-monthly Resident and Family Support Council meeting that we conduct on the second and the fourth Tuesday of every month. This is brought to you by the Illinois Long-Term Care Ombudsman Program, and we advocate for people who live in long-term care. And it is actually sponsored by the Illinois Pioneer Coalition, who allows us to use their Zoom site in order to be able to host this meeting for everybody. Like I said, we conduct these meetings on the second and the fourth Tuesday of every month at 3 o'clock. So always remember that the link that you use to get into today's meeting is the same link that you'll use for all the meetings. So save that link someplace for yourself so that you know you can always get into the meetings. I love it. Typically, a day or two before all the meetings, and then after the meetings, I get a lot of requests for people to be put onto our add to our account so that they can get the invites. So it's wonderful. Keep sharing the information with people. That's how it grows. The purpose of our meetings is to provide people with information that are navigating that long-term care path so that people can feel empowered with that information, so that we can all make sure that we're living that better life that we really deserve to have as we're navigating this long-term care path. So we do a variety of different topics, including today's topic, which we will get into in a minute. But I want to let you know that if for any chance you can't get to our meeting, we do record these meetings and then we place them onto our YouTube site. So I know Stephen typically will be working in the background. I don't know if Stephen is on yet, and be putting the links for all of that information into the chat for everybody. But the long-term care, here he comes. He's right on cue. Here he is. He's putting it all in. I can start seeing into the chat now. So check out the chat because he's putting in there the links to be able to get to our YouTube page and our Facebook page as well. On YouTube and Facebook is where we do a lot of the advertising for these meetings. So like that Facebook page and visit us frequently so you can see what topics it is that we're going to be bringing to you. Like I said a little bit earlier, we bring a variety of information to these meetings. We really feel that it's really important that everybody has that holistic um, information that they can have so that they can live that good life. And that includes talking about health conditions as well. So today we actually have Yvonne Overton from Illinois Department of Public Health, who will be presenting with us about seeing yellow, what you need to know about urinary tract infections. It's that UTI, that urinary tract infection that we hear about from so many people in long-term care. We hear that this is a time when people get these things and then it gets overused. So we're going to really get the right information from Yvonne today. She's going to really help us be empowered so that we can make the care choices that we need to have so that we can live that life that we deserve to have in the right way from the experts. So Yvonne, do you want to just share a little bit first of all about who you are and what your team brings to us all here in Illinois?
Hi, my name is Yvonne Overton. I am one of the regional infection prevention coordinators for the Metro East. And we have a team of 6 other nurses just like me, and we each have our own region. And we work a lot with any congregate care setting, but included in that is long-term care homes. And so we do a lot of assessment of those homes and just looking at their infection prevention programs. And then we follow up on outbreaks and anything that is communicable disease wise and education. So anything like today, we're going to talk about urinary tract infections, which is going to include some of the antibiotic stewardship.
Thank you. Yes, this is really great information for us to have. So we really appreciate you being here today for us, Yvonne. Thank you.
Thank you for inviting me.
Yes, and you should be able to put any slides up that you might have. You should be able to
Okay.
access that yourself.
Okay, let me get started sharing here.
Sounds good. And this team is a really great team that has come together. I know we've, during COVID particularly, they presented a lot for us to really help make sure that the people that lived in long-term care were getting the proper information. And that's what I value about this team that Yvonne is on, because they really are focused in on making sure that people are getting the right information. And we're not going down that rumor mill trap or anything. So that's what's really important about this. So.
Okay, so are you ready for me to start? And if so, can you see my screen?
Yep, we're all good.
Okay, thank you. So I'm going to click through here because I've already introduced myself, but this is the agenda. We're going to go over the urinary tract anatomy, pathogens that are found in that. We talk about urinary tract infections. I'll be calling that UTIs as we go along. Their symptoms, risk factors, diagnosis of a UTI, colonization, prevention, and then appropriate and inappropriate treatment. So as I said earlier, I am from the Illinois Department of Public Health. And so just a little plug for them. It was founded in 1877 with only 3 employees. And now we have 1,200 and 6 regional health offices with 3 laboratories. Let's see, that's Chicago, Springfield, and Carbondale. And many different programs like disease control, healthcare regulation, promotion, protection, policy and planning, emergency preparedness and response. There's racial and cultural health equity, and then women and family services. So a lot going on. But let's get into the urinary tract. So just to go over a little bit of the anatomy, the urinary tract includes the bladder, the urethra, the bladder, and then the ureters and the kidneys. UTIs are common infections that happen when bacteria travel up that urethra into the bladder, usually from the skin or the rectum. And then the female and male have the same uh, uh, function of the urinary tract, beginning with the urethra and the bladder. These images show that, shows how it can just, those bacteria can just travel on up those tracts. And this then shows there's 2 um, different types of urinary tract infections. One is in the bladder, which we call cystitis, or if it travels on up these ureters and gets into the kidneys, that's um, pyelonephritis, and that's when it can make you really sick. So, pathogens are different bacteria, can usually bacteria that get into the bladder. The bacteria are usually responsible for about 95% of these cases. And then among those, E. coli accounts for about 70 to 80% of UTIs. So there's other organisms like Klebsiella pneumoniae, Pseudomonas, Proteus, and then Enterococcus. For the most part, though, E. coli is what we see the most. It lives harmlessly in your gut, but it can cause problems if it enters your urinary system. And this is usually when stool migrates from the rectal area into the urethra. So that's why in long-term care, when we see these UTIs come up and they are E. coli, you'll usually see the nurse addressing that with like monitoring pericare, or doing education to staff on that. We're just always looking at that when we see E. coli. And then as we go into the different types of UTIs, there is acute bacterial cystitis, uncomplicated urinary tract infections, complicated urinary tract infections, recurrent urinary tract infections, and then asymptomatic, this is the hard word, bacteriuria. So it's just an asymptomatic UTI. So the acute bacterial cystitis is culture proven infection of the urinary tract with a bacterial pathogen. It's associated with acute onset symptoms such as painful urination in conjunction with variable degrees of increased urgency to urinate or frequency, blood in the urine, which we call hematuria, and then new or worsening incontinence. So uncomplicated urinary tract infection is just you have an infection in the urinary tract in a healthy patient. Anatomically, everything's normal, everything functions normally, and there's no known factors that would make them susceptible to develop a UTI. Complicated urinary tract infection is in a patient with one or more complicating factors that may put them at higher risk for developing a UTI. So, um, and this also, when it's more complicated, it decreases the efficacy of your therapy or treatment. And factors like those include when there's an anatomic or functional abnormality of the urinary tract. Some people have stones, diverticulum, neurogenic bladder, or immunocompromised host, or they may have a multi-drug resistant bacteria. Then the recurrent urinary tract infections are when there's two separate culture proven or culture positive episodes of acute bacterial cystitis, associated symptoms within 6 months, or 3 episodes within a year. And then the asymptomatic UTI is when there is a culture that says there's bacteria there, but there's no symptoms and no illness. And we'll talk a little bit more about that. So, we have urinary tract infections are common infections in skilled nursing facilities, but they're often overdiagnosed. So there's harms to overdiagnosis and overtreatment. The residents and families play an important role in discussing their concerns with staff and the clinicians. It's just important not to push for a UA or treatment. But if a loved one is sick, then they need to advocate for them and advocate for the appropriate treatment by discussing that with the clinician so that we can really get down to the real issue and making sure that we're not causing any more harm. So let's go into some signs and symptoms, and this is very important. Years ago, I think most of us would say, you just would go to the doctor and you would get an antibiotic for just about everything. But now we're very specifically looking at signs and symptoms in urinary tract infections because otherwise we don't want to be giving medication. So in a bladder infection, we should be seeing in a true bladder infection pain or burning while urinating, frequent urination, that feeling or the need to urinate despite having an empty bladder, blood in your urine, pressure or cramping in the lower groin or lower abdomen, and then in a lot of older residents in nursing homes, incontinence is a key indicator as well. And it can be just in a normal adult. But with a kidney infection, you're going to see fever. People are going to be a little bit sicker as you realize that that bacteria has traveled up the ureters into the kidney. So we're seeing fever, chills, back pain that's located higher. So not lower, but higher where those kidneys are, and then nausea and vomiting. So if someone has bacteria in their urine, we want to know that if what symptoms are they having, and if they're not having any symptoms, then that is asymptomatic bacteria. So those people are what we call innocent bystanders. They have the positive urine culture, no symptoms. That means it's not a UTI. So the term asymptomatic refers to that isolation of, okay, yeah, they do have bacteria present, and it can even be what we're looking for is a specific number. So it's 10 to the fifth, which is 100,000 count of bacteria in the urine when we're looking at that lab result. But then if they don't have symptoms, then it's asymptomatic. And one must have symptoms for it to be considered a true UTI. So, suspected UTIs account for about 30 to 60% of systemic antibiotic prescriptions. So, that includes the inappropriate antibiotic treatment for positive urine cultures without the accompanying symptoms. So, and out of those 25 to 50% are catheterized, and then the others are non-catheterized. Sorry, I had that turned around. 20 to 25 to 50% are non-catheterized, and then you will see in the catheterized patients usually higher. And then there is also a UTI prophylaxis. So that's when an antibiotic is prescribed without even an organism that present in the culture, but they're just giving an antibiotic to prevent a future UTI. So risk factors in the older adult are quite common. So UTIs are more common in females just because their urethras are shorter, they're closer to the rectum. It's just the way our bodies are made. It makes it easier for bacteria to enter the urinary tract. So other risk factors are when we've had previous UTIs, changes in the bacteria that live inside the vagina or vaginal flora, pregnancy, age, structural problems in the urinary tract, poor hygiene for males uncircumcised, and menopause or recent sexual activity. So, when we're talking about bacteria in the urine, this picture is just a scanning electron image depicting large numbers of staph bacteria. These are found like in the luminal surface of indwelling urinary catheters. So of importance though is the sticky substance. And if you can kind of see that here, it's kind of a white, looks portrayed as a white sticky substance there. It's woven all around the bacteria, and this is known as biofilm. So biofilm is a complex structure. It has bacteria, it has host cells and cellular byproducts. And biofilm forms within invasive medical devices. So it is proposed as the primary mechanism of the development of certain infections. So usually, I'm sure you've all seen that slicky substance on things. It doesn't have to just be urinary related, but you start getting moisture somewhere, you get that sticky substance, and it's really a slimy coating that is protecting the bacteria to allow them to grow. And so when it's clearly visible on a catheter, we want to get that indwelling catheter out as soon as possible. But this, like I said, does protect the bacteria, and it really defends against the antibiotic that we want to give to get rid of the bacteria. So we want to reduce that situation where the biofilm is growing, and that's why we want to keep everything clean with soap and water. And when we're talking about indwelling urinary catheters, these are just the parts that show what it is. Here is the actual container for the urine, the tubing that goes up into the bladder and into the urethra, through the urethra, sorry, into the bladder. And so this is the area where we see a lot of biofilm that develops, and then, as you can imagine, that will assist in encouraging bacteria to grow. Approximately 5 to 7% of nursing home residents have indwelling urinary catheters, and the UTIs account for 20% of infections reported by long-term care facilities. So in those long-term care residents, the risk factor for developing a UTI includes age-related changes to the urinary system, and like in women, also hormonal changes. But when you add in that urinary catheter, then it increases those chances of developing infections. So when that happens, we call that a catheter associated urinary tract infection. CAUTI is the acronym for that. And so some people are just at high risk because they have the indwelling catheter. And if a person develops an infection while they have the catheter inserted, it's deemed associated with that catheter. In a hospital setting, of course, they track these and have to report them. There's just a whole different type of system. And they've talked about that for years of tracking this in long-term care, and that hasn't begun yet. But um, we do know that it is a risk factor for developing severe infections in the elderly. So 50 to 70% there of CAUTIs are thought to be preventable by taking the recommended infection control measures associated with care of an indwelling urinary catheter. These catheters can lead to cystitis, pyelonephritis, bacteremia, and septic shock. In a 2022 report issued by the National Institute for Health, the annual cost per case has been estimated to be between $31,000 per hospital stay. A cumulative burden of these infections was estimated an annual cost to the nation's healthcare system to be about 45 billion in direct hospital costs associated with urinary tract infections related to indwelling catheters, and then the cause of nearly 100,000 deaths annually. So surveillance criteria are used to count true case events and to estimate actual incidence of disease conditions. Surveillance criteria are designed to increase the likelihood that all patients counted truly have the infection present. So because of infections in long-term care patients might not have typical symptoms, failure to meet surveillance definitions does not always mean there was no infection present. I'll just highlight how a few of this criteria are reviewed. So what the nursing staff will do in long-term care are review this McGear's surveillance criteria, and this helps them determine if this is an actual urinary tract infection and not just what I was talking about earlier as an asymptomatic bacteremia or bacteriuria. So they're looking for at least one of these signs and symptoms like fever, new onset hypotension, acute change in mental status. And these are symptoms I want to reiterate that for indwelling catheters, suprapubic pain or the costovertebral angle pain. And that is simply meaning that back pain over the kidneys, if that's tender, if they have purulent discharge around the catheter, acute pain or swelling. And then is there a urine culture that shows 10 to the 5 colony forming units per ml of any organism? So that means the count is going to be 100,000. It has to be that to meet. And that is the criteria that would tell a nurse, okay, we have a true urinary tract infection here with an indwelling catheter. And I just want to make note too, this is the only instance where you use acute change in mental status, and none of these do you use color or a smell of the urine. So colonization is when an organism is present in the urine but causes no symptoms. So it's kind of two things that we're talking about when I'm saying asymptomatic is no symptoms, but there's an organism present. It also means they could be colonized with this. So we don't test for a cure after we have treated someone for a UTI, and that means that there shouldn't be a repeat urine culture being done after that, because many times the organism can still be present, which means that that person is colonized with that organism. It's just not causing them any symptoms at the time. The organism can remain present in the body, actually not causing any symptoms. And what we've seen historically is repeat cultures were done after, like, say, 2 weeks after an antibiotic was stopped. And if they saw that organism there, even though the symptoms were gone, then they would order another antibiotic. And so this is what we've been seeing sweep across the country nationally, that has caused a development of these bacteria to become resistant to antibiotics. So you may see urine cultures be positive and then negative, but overall research has shown that the organism still lingers ever present in the body and what you may call dormant in the body until it becomes active, causing symptoms. And then you would see the symptoms at that point. So we spoke on the previous slide about the complications of CAUTI or the indwelling catheters and what we can do to prevent CAUTI. There's evidence-based guidelines that we can practice to prevent that. And so they want us to only insert catheters for appropriate indications and leave in place only as long as needed. So we want to minimize urinary catheter use and the duration. Um, we want to check for bladder retention. Um, there are several diagnoses that will require um, indwelling urinary catheters, and bladder retention is one of those. That means that the bladder can't let go of that urine on its own. And so, is an accurate measurement of the urinary output needed? We would have to use a urinary catheter for that. Does the patient or resident who's incontinent have an active sacral or perineal wound? A lot of times, it's very necessary to use an indwelling catheter when there are wounds there so that they can heal. And does the resident require prolonged immobilization? Would be another one. And when we want to talk about prevention, it's very important. So we want to stay well hydrated, avoid constipation because, well, a few years ago, I was involved in a project in an acute care hospital on UTI and actually how antibiotics were being prescribed. We looked at the emergency department use and then patients that were admitted. And one of the things that urologists stressed was avoiding constipation in older adults, because once you are constipated and that fecal material sits there at the end of the colon, it causes it to just move and go into the urethra, and it just makes its own little path, and then you're going to see UTIs. So in nursing homes, when we see maybe someone having a frequent UTIs, we want to check to make sure that they're having a normal bowel movement. So take showers instead of baths. Minimize douching, sprays, or powders in the genital area. We teach girls when potty training to wipe from front to back, so we want to continue that through adulthood. And then, of course, urinating after sexual activity. Some other ways we can involve prevention with just normal acts of daily living, I guess you would call it. We have alternative remedies. There's pineapple juice. It has an ingredient called bromelain, and bromelain causes the body to make substances that fight pain and swelling. So this has been used to decrease inflammation in a urinary tract infection, just allowing the bladder to empty easier. So bromelain also contains chemicals that seem to interfere with tumor cells and slow blood clotting. So you would uh, people use it for muscle soreness, pain, burns, kidney stones, and many other conditions. But because it slows blood clotting, using it in combination with other medications like blood thinners could increase the risk of bleeding and bruising. So you always have to consult your physician prior to starting any of these alternative methods. Can't stress that enough, actually. So but it is pineapple juice has been shown to really help relax that inflammation. Then cranberry juice, especially the juice contraints you find at the grocery store, will not treat a UTI or bladder infection. So it can offer more hydration and possibly wash bacteria from your body more effectively, but the active ingredient in cranberry is long gone by the time it releases into your bladder. So while cranberry may help, uh, it helps some people prevent UTI recurrence, but there's no evidence based research that really says that it does. We think that really it is most likely due to you're increasing the amount of fluid that you're taking in. And so you're just kind of helping to flush that bacteria out. So then the last one there is the dandelion tea. So dandelion is a natural diuretic and it helps eliminate toxins from the kidneys and the urinary tract. The herb also acts as a disinfectant, inhibiting bacterial growth in the urinary system. So with all of these, we just want to put them out there as for education. Um, they they're not, I mean, I should say, we always just want to stress that you contact your physician prior to choosing any of these prevention methods, but we do want to educate you on those. So when we're talking about the actual treatment, we're talking about what the provider has prescribed. So taking antibiotics at home can treat most UTIs, and your healthcare provider might also recommend medications to help lessen pain or discomfort. And then sometimes the cases do become septic. We have seen that in older adults, that maybe their immune system is not as robust and they may require treatment in a hospital. So anytime you take antibiotics, they can cause side effects. The side effects can include rash, dizziness, nausea, diarrhea, or yeast infections. And then taking too many antibiotics can cause diarrhea. And this can lead to severe colon damage and death. And C. diff is the main cause of that. And I came from acute care. I've seen that so many times where people suffer from C. diff. And so we have to be very careful when we're taking those antibiotics. Just call your healthcare provider if you develop any of the side effects or if something starts changing that you're not sure about, and ask them their opinion on that. You need to alert them if that's going on. So treating asymptomatic bacteriuria has no benefits and only causes harm. So as I was just saying, with the C. diff infections, it increases the cost for the patients, it lengthens hospital stays, and then the most prevalent thing we're seeing nowadays is this antibiotic resistance, where it's becoming hard to find a treatment for these pathogens because they are becoming so resistant to all antibiotics. 2.8 million antimicrobial resistant infections occur each year. More than 35,000 people die as a result. And that was from the CDC in a 2019 threats report. And so when C. diff, it's a bacterium that is not typically resistant, but it can cause that deadly bacteria, what I was talking about. It also increased those threats to 3 million infections and 48,000 deaths from that 2019 study. So the estimated national cost to treat infections caused by 6 antimicrobial resistant germs frequently found in healthcare was more than 4.6 billion annually, according to that CDC survey and research. So just remember, if you have foul smelling urine, or your family member or resident, urine colors off, there's cloudiness, altered mental status alone, like more sleepy or confused, there's no UA needed. If fever or they have leukocytosis without urinary symptoms, you shouldn't be ordering a UA. And of course, from a standpoint where you're talking to a urologist, they always emphasize that if you're going to get a UA, then you should always have a culture, because a culture order, that if it would reflex to culture, you can go ahead and get that, because then you have something to stand on and something to treat. But we no longer just say, oh, the urine looks dark, we need a UA. So just those are maybe changes for some people, but these are very important things that we need to follow to reduce that antimicrobial resistance that we're seeing across the nation. So these are just the decision points that a provider will be evaluating. is improving the use of antibiotics to protect the patients. First, they're going to order the UA if they're symptomatic. They have to interpret that UA, order the culture, and then treat or adjust treatment based on those culture results. So, antibiotic stewardship, which I refer to, refers to a set of commitments and actions designed to optimize the treatment of infections while reducing the adverse events associated with antibiotic use. So, the CDC recommends that all acute care hospitals implement an antibiotic stewardship program, and as well as long-term care. And we have to take steps to improve antibiotic prescribing practices and reduce inappropriate use. So, how to feel better? We want you to drink plenty of water and other fluids. That keeps you hydrated, but also keeps the bladder, um, just washing out the bladder and washing any bacteria out. If your healthcare provider prescribes you antibiotics, we want you to take those antibiotics exactly as they prescribe. Don't stop them early. Take the entire prescription as prescribed. Don't share your antibiotics with others. Don't save the antibiotics for later. So, if you have any leftover antibiotics now, please talk to your provider about how to safely discard those. And then, if you have any questions, please go back to your healthcare provider and ask those important and vital questions. Do you have any questions for me? Thank you for listening to me and talking about urinary tract infections.
Yes, well, thank you, Yvonne. It was really good information. If anybody has any questions, do feel free that you could either raise your hand, that way then I can see it on the screen that you have a question that you would like to ask, or you could also put it into the chat. But I know while we're looking to see if anybody has any questions, I have some questions for you. I'm curious, you said about the confusion piece, because I know many times in long-term care, they use that as a criteria for people that might have a UTI. They say that there's increased confusion, so let's see if they've got a UTI or not. But you said it's only true with the catheter if they have a catheter. Why is that why is it if a person has a catheter, that that would be then considered a symptom?
So they've found that, and across the nation, doing research, that for just a normal a urinary tract infection, there are only specific criteria as the symptoms that I went through that would meet criteria for a UTI. So when you have an indwelling catheter, it increases the chances of other things going on, and it can cause like more severe symptoms. And so when you have confusion, you have to have something else present. So usually like a fever, hypotension. There's going to be other things hand in hand with that confusion. It's not just going to be like historically. You would hear families say, "Well, my mom always gets confused. We know she has a UTI, and there's no other symptoms." And
Hmm.
what we know now is that is not a symptom of just a UTI, and people were being treated inappropriately and increasing this antibiotic resistant that we see across the nation because they shouldn't have been treated in the first place. So it only holds true when that indwelling catheter is present because there's going to be more severe symptoms arise.
Okay. Yeah, because that is something that I've heard for years, in long-term care. That's kind of been the thing that everybody says. Well, oh yeah, they've got increased confusion. They're going to the bathroom more. They must have a UTI. And that seems like that's the quick criteria, really, quickly.
Right.
And when they're not exploring it enough. So that's why this information that you shared with us is really valuable. Because I had no idea that it was just with the catheter piece.
Right. And I think the McGear's criteria that we see, it's really critical that the nursing home staff are using that because it gives them exact criteria to use. It tells them exactly if they meet for for an antibiotic, and
Hmm.
it decreases the chance that they're going to get treated inappropriately. When you
Uh-huh.
see someone who gets systemic infections. They can get really sick from urinary tract infections. But what we're finding is because not just families, but even us as nurses, we're scared they're going to get to that point. And
Hmm.
so we would just want to hurry up and treat that. But what it has caused is this buildup of resistance because they didn't really need it at that point. And then they get to where, okay, they have a systemic infection and they're septic, and we're having to use more expensive drugs to treat that. We're finding, it's a more narrow uh, set of drugs that will work, or antibiotics. And so we're getting less and less antibiotics that will even treat that person. They're more expensive, and then it's going to cause their hospital to stay longer, their treatment to be longer. Many times I've seen they've come back to the facilities with indwelling um, catheters, pick lines or whatever, so that they can get antibiotics IV for 30 days or whatever. And it just really changes the whole
The
dynamics
course of,
of that.
yeah, and the course of what someone's going through, it can really just affect, I feel like it can really affect people. I'm, what is the threat to having to having too much antibiotic? What is the threat to the body with that?
Well, the first threat was what we see most normally is that people develop C. diff because
Okay.
it alters your bacteria in your gut, and it allows bad bacteria to grow. And then C. diff is just another thing that you can become colonized with. So um, we've seen in the hospital setting where someone will have C. diff because they've taken 3 or 4 antibiotics trying to get rid of a UTI, or maybe not just a UTI, maybe it's something else, but they develop C. diff from that, and
Hmm.
they've had it for the rest of their life. And some people die from that. Some people just can get another, get rid of it, and then it comes back later. So you don't know. It's like kind of playing Russian roulette. You don't know what's going to happen, when you take all of these antibiotics.
So now C. diff, just to speak to that for a moment, since it is something that can happen as a result of the antibiotic use, is that something that doesn't leave your system? It stays in your system once you have it? And can you also speak to what it actually is? What is C. diff? For people just to understand that.
So it's a bacteria. Well, it's a spore actually, but it is can get in your live in your colon, um, and causes. I mean, it's highly contagious. It usually lives on surfaces for a long time. It can only be killed on surfaces by bleach. So if you don't know it's there, it can be passed to the next patient when they come into that bed. If the bed's not cleaned appropriately, bleach, like I said, is the only thing that will kill those spores. And um, if you have too many antibiotics that kill the good bacteria, then it allows the bad bacteria to grow. Speak to that 100% you're colonized, but I have seen they do believe that any of these bacteria stay in your system, kind of like people with chicken pox, and then it becomes kind of like latent, and then later in life can become shingles. It's not the same thing, but I'm just using that as an
Right.
example to kind of explain what a colonization is. It is an organism that would live in your body, kind of go dormant, but can come back. Say, if your immune system kind of dips, or just the right situation arises, it'll flare back up. And they know that these, especially the multi-drug resistant bacteria, they know those are that way, that they are colonizing people. And C. diff, I'm pretty sure that it is the same way. Although, there are cases where they have been believed to be cured. But I do also know of lawsuits that occurred where people actually, like, say they got an HAI, so they got that in a healthcare setting, and were able to prove that they never had it before until they received all of the antibiotics, and then got C. diff and was never able to get rid of it.
Mm.
So it's a serious condition.
Yeah, yeah, I know you hear about it in the nursing homes as well. Many times it seems to be something that you hear about in the long-term care facilities, and I know it complicates a person's life. I recognize that. So I have another question for you regarding some of the risk factors. Why is age a risk factor for getting a urinary tract infection?
Well, a couple things. Uh, First of all, just our anatomy begins to shrink, and even your bladder isn't held up as well as it is when we're younger. Just the muscles all relax, the ligaments relax, and so your bladder and urethra are closer to the rectum.
Hmm.
And then the second most important thing is our immune systems just get weaker and weaker as we get older, and so we can't fight off those bacteria that maybe normally our body could when we were younger.
Okay, that makes a lot of sense. That would be a reason why. I feel like that's one of the things that happens with our bodies. I do say to my mother, who's 92, I say to my mom when she says, "Well, this isn't working like it used to," or "This hurts me now," and I'm like, it's not like a car we could go in and get that replaced. It's just there. You got it, and you just got to work with it, and we've got to figure out how we can make your quality of life better if you're experiencing something like that. So. Um, and I also am really curious, this whole, urinary tract infections. I've worked in long-term care for many, many, many years. And I feel like many times urinary tract infections feel so common. And I'm feeling like because we are this overdiagnosing of this. And I know one of the things that also nurses aides say amongst themselves, and I think I've even said it, the nurses aide many times are the first person who seems to notice that there is and that are suspicious that the urinary tract infection is happening because of the care that they are providing. And sometimes I wonder if they are over because what I hear so many it's tied to is this confusion piece. I really do. I hear it's tied to it. So I feel like the information you're sharing is so important for us to hear because it's dispelling some of these myths that we've
Right,
heard
and
for so
the
long.
key there too, and it's not just long-term care, but as we get older, we don't drink as much fluid as we should, so we're not keeping hydrated, and we're just not flushing out our system like we should. Then when you do, unfortunately, when you get into long-term care, it seems harder to get that done. And there's just a lot of circumstances nowadays. I know, many I just know many long-term care facilities that I visit are fighting for staff. Um, they need to have the staff that can just like if they had volunteers that could go in and get advice from the nurse who can have this drink and help to hydrate people. I think would be wonderful because that's one thing we really need. If it's monitored correctly, through the nursing staff, we don't want people just going in there and giving people fluid who possibly can't have it, but if there was some type of um, uh, process we could develop, that
Yeah.
uh, get volunteers or something to help um, just
Yeah, I
keep.
used to work in a nursing home where I consulted, and they would have in the summertime, they'd get some high school volunteers, and they would be in charge of the hydration cart. And they would go around the hallways, and they had it decorated really cute, almost like a lemon, like kind of like a little old lemonade cart kind of a thing. And they'd go around passing water to everybody and making sure that people were getting fresh water, even that had water. Fresh water always just tastes better. If you got it in the morning, you want more water, different water in your class in the afternoon. And I thought, what a great thing that they were doing. And it gave these kids that opportunity to be in the long-term care facilities as well and see what the world is like and maybe someday take that path for themselves to work. So yeah, great, great information. Um, and then I had one last question that came to my mind when you were talking about catheters, and that they need to be. I know that that can be a big issue with making sure that it's clean and that's where a lot of infections can happen at that with the catheter. What is the recommendation? Is there a recommendation for the frequency that a catheter should be changed? And I'm not a nurse, so I'm curious about all of that.
There's really not. I
Hmm.
think they used to say 30 days, but I don't think, I mean, I see Ramona Barger on here. She might know this question better than me. um, uh, but anymore, it's changed, when, so you need to change it before, like, you're going to get a culture, and because you want to make sure there's nothing on that before you're getting a urine specimen. But they really are not wanting you to mess with that. Like, they want it to be changed only when needed. And so some facilities will still say like 30 to 40 days they would change it, but I don't think there's a requirement, that of when it has to be changed.
And what would identify the need for that to be changed if there isn't a standard for it?
Well, like, it's just some of the things are simple, like pain, discomfort at at the site. Um,
Okay.
if you're seeing some discharge, bleeding, um, and if the patient is having symptoms related to the catheter. And then you have to also go, think about those things that I mentioned on the one slide, is if there's some places the nurses can do that on their own without the order, but sometimes they would need a doctor's order if
Hmm.
say the patient has a neurogenic bladder, um, if it's in there for healing, like there's a wound that's close to that site, like a sacral wound, and they need that in there, so that wound can heal. You really want to consult with the provider before you would make any changes.
Okay. Okay. Well, great information. Again, thank you so much for being here today. You helped me. That's what I love about these meetings. I feel like I'm getting, information from areas that I probably would never even, I wouldn't even been thinking about this stuff. So I really do appreciate you sharing this today. It's important. Like I said, I have an aging mother myself, and her thing, she's had a couple of UTIs way long ago, and she showers every night, and that's what helps her. That's just, that's what she does. And that's how she really keeps herself, making sure that it doesn't happen again because she doesn't want them. Nobody wants these things. So thank you so much. I don't know. I'm going to go ahead and I'm going to stop the recording right now. And if anybody has any questions, we can go ahead and we can continue on just for a couple of minutes to see if anybody has any further questions.